Yeah, I'm ready.
Okay, sir. So within a 10 second, we are live to audience the platform, sir.
There are volume trickles. Yeah.
So it's three, two, one. Over to you, sir. We are live to audience the platform.
Thank you. Thank you, Novelties, for giving this platform to talk about a very, very important subject. This is a Imaging Health saying, and Benito is the molecule we are talking about. Newer CCB for the management of
Okay,
hypertension. And
sir, first of all, I will give you a brief introduction, then I will hand over session to you.
if you do that,
Yes. Okay, so good afternoon, everyone, and welcome you all in today's session. Today, we are delighted to welcome Dr. Kamal Nahata, sir, a highly respected senior cardiologist and diabetologist from Guwahati. With vast experience in the field of cardiology and diabetes care, Dr. Nahata sir has made significant contributions in the management of hypertension in cardiovascular disease. In today's session, Dr. Nahata sir will be sharing valuable insights on newer CCBs for the management of hypertension and end organ protection, highlighting the latest advancement in treatment approaches and their role in improvement patient outcomes. We warmly thank to Dr. Nahata sir for joining today's session and sharing his valuable knowledge and experience with us. So, without further delay, we would like to hand over this session to you, Dr. Nahata sir. Over to you, sir.
thank you, Jansi. And thank you, the company, for giving me this platform to talk about things. Hypertension. Most common disease is hypertension. Now, all chronic disease among the hypertension is the highest rated disease, and then comes diabetes. Most of the death and hypertension is called silent killer. Okay, please move this. And hypertension never comes alone because hypertension and severe disease. Hypertension accelerates the development of atherosclerosis. Everybody knows, destabilize vascular lesion and precipitate acute coronary event. Therefore, it is important to achieve and maintain a good blood pressure control. We always say maintain a good blood pressure control. When patient with hypertension come, they say 2 days can we stop medicine? I say stop food but never medication. It is how important the hypertension is. The goal of therapy is to reduce the morbidity and mortality associated with both hypertension and chronic heart disease. Now, this is why we give the lifestyle modification, hypertension risk factor like hypertension risk factor with dyslipidemia, diabetes, obesity, other smoking, genetic factor. These all things are part of our chronic health system, and most probably hypertension and CVT, these all play much role. Patient having hypertension risk factor, we have more chance of CVD, stroke, and cardiac or coronary heart disease. So these are the stages of heart disease. So why I'm stressing first on men that hypertension is very, very important, and CV disease along with leads to most of mortality and morbidity in our patient. Everyone should take care of hypertension. Next. Now, hypertension CVD, just to give a global view, cardiovascular events are responsible for more than million deaths each year, more than million deaths. High blood pressure is well recognized remediable risk factor for CVD. But that means remedial means we can control it, we can remove it. Systolic blood pressure more than 120, between 120 to 129, was associated with increased risk of CV event, CSD, and stroke. So, BP control is of paramount importance in decreasing CVD risk. For example, if we can reduce systolic blood pressure by 3 to 5, it reduces stroke incidence by 2 to 3%. See, almost same number. Decrease in CV morbidity and mortality resulted from a 10 to 12 millimeter reduction in systolic blood pressure and 5 to 6 millimeter of diastolic blood. How important this is. So CV morbidity and mortality also becomes less if we can reduce blood pressure. Next, hypertension and chronic kidney disease. Hypertension is recognized as the biggest contributor to global burden of disease, and we know almost all kidney patients to some extent are because of hypertension or diabetes. So hypertension is the biggest contributor to the global burden of this disease, common in CKD, and it may aggravate it to end-stage renal disease. We see so much chronic kidney disease rising with dialysis, transplantation. So basic root cause, if we can control the hypertension, we can hold the disease and the progression of disease is definitely become less. Patient with severe CKD where eGFR is below 30, not on dialysis are of high or very high CV risk according to TC. Most of the cardiac, renal patient chronic, they die of CVD. Analysis made by CKD Prognosis Consortium have demonstrated that both estimated EGFR, urinary albumin creatinine ratio, are independent prognostic factors for mortality. Thus, optimum BP control is very essential. The bottom line, optimum BP control is very essential. Next, hypertension and chronic kidney disease. They are closely associated with an overlap of intermingled cause and effect relationship. Both are related. Decline in kidney function, agent progression of kidney function decline, and rise in blood pressure, sustained elevation blood pressure. To and fro. If there is a decline in kidney function, we find rise in BP. And if sustained elevation in BP is there, it leads to progression of kidney function decline. Both are there. So both must be controlled, and hypertension is more easy to control. Prevalence of hypertension in CKD, 89%. That means whatever CKD patient you are seeing had history of hypertension or are having hypertension, 89% is a very huge number. Mean nocturnal systolic blood pressure predicts ESKD, end stage kidney disease or death. Dipping patterns are blunted in individual with CKD is concerning and the important for management of hypertension in patient with CKD. Next. Now, molecular mechanism in hypertension with CKD. What molecule? We know that peptide hormone, sorry, angiotensin 2 is an important mediator in pathophysiology of arterial hypertension. See, this peptide hormone angiotensin 2 for arterial hypertension, hypertensive end organ damage, and also hypertension kidney failure. Angiotensin 2 exert indirect effect via changes of the glomerular hemodynamics. See, that is the basic glomerular unit of kidney, and it exerts indirect effect via changes in glomerular hemodynamic or glomerular pressure, leading to increased filtration pressure, leading to increased filtration of sodium chloride. Angiotensin 2 from systemic circulation increases tubular expression of angiotensin S, renin, and AT1R. Elevated levels of angiotensin 2 leads to severe injury of glomerular podocyte. Podocyte being the main. See, this is very important thing that elevated level of angiotensin 2 leads to severe injury of glomerular podocyte and ultimately podocyte loss. So podocyte depletion is an irreversible hallmark of glomerular injury, and that is where we know CKD is starting. And beneficial effect of angiotensin 2 blockage. So because angiotensin 2 rise is causing this, so if we can have the angiotensin blockade on the progression of hypertensive CKD correlate, and that can attenuate podocyte loss, and if podocytes are not lost, there will not be any irreversible damage to the kidney and hence patient. So this is a very important point to know that peptide hormone angiotensin 2 is a mediator in pathophysiology. If we can block their effect, so that's what leads to this podocyte loss and attenuation. So if podocyte can be made to stay longer and irreversible damage is not there, glomerular injury in CKD will not affect, and this will beneficial effect of angiotensin 2 blockade on the progression of hypertensive CKD or attenuated podocyte loss. Next. So podocyte is a very important thing. If we can prevent the loss of podocyte, we can prevent the hypertensive complication. Next. Now podocyte damage. See, destruction of the podocyte can lead to massive proteinuria, but the large amount of protein is lost from the blood. So we can give sequence-wise podocyte injury occurs because of angiotensin 2, that peptide which causes arterial hypertension. That leads to podocyte stress, and podocyte stress on long-term causes podocyte apoptosis. That means death. Podosine and nephrin are go from the podocyte apoptosis, protein loss. These podosine, nephrins, and protein loss that causes proteinuria, and proteinuria continuously or high rise and albuminuria causes end-stage kidney disease, and podocyte apoptosis that way causes glomerulosclerosis. See the two things. Podocyte damage will lead to glomerulosclerosis, and it will lead to heavy proteinuria that will cause end-stage kidney disease. So podocyte damage is very important, and how to prevent podocyte, because adipoamyllectin can be prevented by S blocker. Next. Now, CKD is a risk factor for CVD. CVD, cardiovascular disease. CVD is the most common cause of death in CKD patient. Whenever patient of chronic uh, kidney disease is there, you can see uh, in CKD patient, CKD is an independent risk factor for CVD. So most of patient of CKD die because of CVD. Decline in EGFR correlates with CVD mortality. EGFR less than 60 per minute, there is a 16% increase in CVD, and EGFR below 30, there is a increase of 30% in CVD mortality. So decline in EGFR correlates with CVD mortality. So CKD as a risk factor for CVD. Microalbuminuria confirms 50% increase in risk of CVD. Macroalbuminuria confers 350% increase in risk of CVD. When macro is too much, that is macroalbuminuria, it causes 350% increase in risk of CVD. These are the data. So what we learned is that in this patient prevention, CKD has to be prevented. CKD precursor is mainly hypertension. Hypertension causes podocyte loss. Podocyte loss causes glomerulosclerosis and causes proteinuria. That all things lead to CKD. CKD lead to increase in CVD. So now we understand the hypertension being the basic cause for causing all these things. Then next. Next, Jessica. Now, CKD risk stratification. Let's see the latest update. Next. CKD and risk management. This is as latest as ADA 2026 update. And we can see this is cumbersome slide, but what we see that risk of CKD progression, CVD and mortality, frequency of visit, and referral to the nephrology according to EGFR albuminuria. What we learned, the number of boxes, these are a guide for frequency of thing. Green reflects no evidence of CKD. We see in skin 1, normal or high blood pressure at early stage. Then we see the high blood pressure, gradually going, causing more. Once per year, yellow, twice per year, orange, twice, thrice per year, red. So these are all for saying that CKD and risk management are important thing. Risk of CKD progression leads to CVD and mortality. So this is very important to know. And as late as ADA 2026 guidelines say, manage CKD to control blood pressure. Next. Now again, European Society of the Hypertension saying that high normal blood pressure, grade 1, grade 2, grade 3. So hypertension, high risk if your systolic blood pressure is more than 180. Very high risk, very high risk, very high risk. Stage 1 also, 2 and 3. So earlier, now stage 1, if we see the high normal, these days we do not quote hypertension 1, we call high normal, grade 1, grade 2. So we must see that risk stratification according to end-stage general disease in hypertension. This was by European Society of Hypertension 2024. What we learn is that high normal blood pressure must be controlled because this is low risk will be more. And stage 1 between 140 to 150 also low risk, and grade 2 moderate risk, and grade 3 when systolic blood pressure is more than 180 is very high risk, very high risk. So this thing has to be known. We must keep blood pressure under control. Next. Now, Now, after hearing all these things about the complications and all, what is the management of hypertension? Let's see the latest update. Now, 2025 AHA-ACC guidelines that management of hypertension. First line agent is thiazide type diuretic, long-acting dihydropyridine CCB, ACE inhibitor, and ARB. Now, this is a level of evidence is A and class of this recommendation 1. This is for adult initiation antihypertensive drug therapy, thiazide type diuretic, long-acting dihydropyrin, that is CCB, and ACE, ARB are recommended as first-line therapy to prevent CVD. So this is the level of evidence and current recommendation. What we see that we can start CCB, we can start long thiazide type diuretic, we can start ACE or ARB. So recommendation for choice of initial monotherapy versus initial combination drug therapy, class, level of indication BD, and recommendation of initial medication 1, 2A, 2B. These are all recommendations which we see in our different protocol. Adult with type 2 hypertension, initiation of antihypertensive drug therapy with two first-line agents is more better of different class. Ideally, in a single pill combination, as PCB code, is recommended to improve BP control and etc. So, not one drug increasing dose, two drugs of different class, and giving combining together, it is a level of evidence BR, and class of recommendation is 1. In adult with stage 1 hypertension, between 130 to 139 and diastolic of 80 to 90, initiation of antihypertensive therapy with a single first-line antihypertensive drug is reasonable and to be monitored, and gradually, if it is not controlled, we can add a single pill or also along it in a single pill combination. Next. Very, easy in a thing, but then thing is that class of recommendation 1, level of evidence A. This is what we say recommendation for hypertensive treatment in patient with CKD. This is as later AHA 2025 guidelines. What this guidelines say? Class of recommendation 1, level of evidence A, that is the highest. So for adult with hypertension and CKD as identified by below 60 eGFR or albuminuria of more than 30, albumin creatinine ratio more, should target an initially systolic blood pressure goal to bring it below 130 millimeter mercury to decrease all-cause mortality. This is a very important thing. We must see that anyone having more than 130 eGFR below 60 and albuminuria. And another is for adult with hypertension and CKD as identified by eGFR below 60 or albuminuria more than 30. RAS, either S or ARB, but not both. They are never combined together. Is recommended to decrease CVD and delay progression of kidney disease. So these both are highly class of recommendation, level of evidence 1 and B. So these things we must know from the beginning. Next. Now again, 2024 ESC guideline, management of hypertension, European Society of Cardiology. They say prefer single pill combination or 8, step 1 dual combination. Step 2 you can give triple one also. So what we find is that in CKD, we can use SCFG2, MRSA, Fineron, not in combination with other MRA. So other MRA will not combine Fineron, but then otherwise they can start AS or ARB. The resistant hypertension, of course, we can give the third drug also. Consider to control hypertension especially. That is all we are specialists, but then those general physician, we say you consider hypertension. If in spite of giving three drugs, blood pressure is not controlled, the different level hypertension we call resistant hypertension. Next. Now, continuation of management of hypertension, 2024 5 AHA-ACC guidelines for prevention, detection, evaluation, and management of high blood pressure in adults. 2024 ESC guidelines for the management of elevated blood pressure. Elevated blood pressure, these days we use the word, and hypertension. Calcium channel blocker are among the drug class that form the basis of hypertension treatment. Every one of us was amlodipine, nifedipine, and all. These all are calcium channel blocker. Next, calcium channel blockers. Next. Now, calcium channel blockers have been one of the most widely used class of antihypertensive agent in last 2 decades. So, effectiveness in reducing blood pressure level, yes, good tolerability and abundant evidence on reducing CV and renal consequences of hypertension. So, since 20 years, we know CCB are there and we have been using. They have been very effective in reducing blood pressure level, very well tolerated, and we have enough evidence. The Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, JNC7, very renowned national committee talk, and other international guidelines currently endorse CCP as an initial therapy option, with essential hypertension. As compared to other class of drugs like diuretics, ACE, ARB, and beta blocker, CCB reduced major CV event, CV mortality, risk of congestive heart failure, and myocardial infarction. So calcium channel blocker are with us and has been staying. And for last 20 years, we have a good control, good confidence in reducing blood pressure level, very well tolerated. Next. Now, types of calcium channel blocker and distribution. Now, this calcium channel blocker disrupts the flow of calcium through the calcium channel. There are about 6 types of calcium channel which are present in our human body. Very important. And this is recently lot of other L type, N type, P, Q, R, T. These are different calcium channel which are present. Now, type L is long lasting. See, L lasting, long lasting. Distribution of these channels, the heart, cardiac muscle, vascular smooth muscle, especially arterioles, skeletal muscles, and bone cells. A dominant, of course, is heart. Now, N type, it is in a brain, neurons. N for neuron, brain, throughout brain, peripheral nervous system. So this is a type N. And type T, we have said 6, L, N, T, P, Q, R. So T is a heart and cardiac muscle, vascular smooth muscles, kidney, afferent and efferent arterioles, renal tubules, DCT, that is collecting duct, and adrenal gland and bone cells. We even have L in bone cells. Okay. Next. Now we are talking about one molecule, which is a very novel molecule. That is, as we have heard, nifedipine and all. This is benidipine, a novel calcium channel blocker. Next. Now, it is novel means what? Potent dihydropyridine calcium channel block developed and it was approved in Japan in 1991. This is Japanese molecule. Now, this is a triple calcium channel blocker. We talked about different 6. We talked about L is a long type in the brain, in the cells, muscle, N type and T type calcium channel, and in the neurons in the brain, and T type calcium channel blocker are also there in the cardiac muscle, skeletal, and in the bone cell. Potent antihypertensive and anti-anginal agent. This benidipine, novel CCB, is antihypertensive and anti-anginal agent. It is used once daily. Noteworthy pharmacological action with fewer adverse effects. Next. Now, benidipine, we will talk L, N, and T type channel blocking action, lowering blood pressure in different arterioles and potentially reducing glomerular hypertension. High vascular selectivity and protective effect on vascular endothelial cell, because vascular selectivity also affect on vascular endothelial system protective effect. Renal protective effects seen in several basic and clinical studies that was observational study. Antioxidative action and enhancing nitric oxide production have been noted with this drug following its cardioprotective effect. That's what we have seen. Better prognostic effect than other CCB in patient with vasospastic angina. We said initial one, it has got anti-anginal effect. So better prognostic effect than other CCB, especially patient with vasospastic angina. Reliable antihypertensive, renoprotective effect if used in combination with ARB, when monotherapy alone is not beneficial. Next. Benedipine, we have more than 30 clinical trials, 2 RCT in Indian hypertension patient, 10 in against amlodipine, 2 CT against cilnidipine, 1 clinical trials against azithromycin. We do not use much, and 4 RCTs against nifedipine, 1 trial against atenolol and valsartan, and 4 comprehensive reviews. Next. To give confidence, we have more than 30. Now, mechanism of action of different other calcium channel blockers. Conventional CCP, how the calcium channels block, bind only directly, and membrane approach directly, DHP, dihydropyrin, bind directly as well as indirectly, high affinity for cell membrane, high lipophilicity, and longer retention. So this is how benedipine works. See, conventional CCB is like this benedipine is a membrane approach directly bind effect for cell membrane high affinity because it's high lipophilicity and that's why it is longer retention. Next. Now, benedipine is a triple calcium channel blocker. We said initially, block L, N, and T type calcium channel. So, L type calcium channel in the blood vessels that causes vasodilatation, reduces vasodilatation. Now, N type calcium channel, sympathetic nerve ending, we N for neurons, as we say initially, blood vessel, it decreases vasodilatation. Now, heart honey is a beta adaptation. It decreases cardiac contractility and hence it reduces heart rate. Now, norepinephrine release from this honey causes increased renal blood flow and decreased renin secretion. Renin secretion is decreased, but renal blood flow is. This is how benedipine works. So we have 3 types of calcium channel blocker, L, N, and T type. So these all works here, and we can see N type calcium channel blocker and T here, and we see L type in a vasodilatation reduction in a blood vessel. Next. Little complicated, but if you once understand, it is the mechanism of action at T-type calcium channel blocker. How? T-type calcium channel blocker, adrenal gland, so it decreases aldosterone production. Aldosterone from adrenal. T-type calcium channel on kidney, it decreases glomerular hypertension and it reduces renin secretion, reduces inflammation, and that way it reduces proteinuria. So benedipine triple calcium channel blocker block L, N, and T type. See how we can see T type works on kidney and T type works on the adrenal gland also. Next. Benedipine less incidence of pedal edema because it dilates arteriole, dilates venule, and that is the reason it causes less pedal edema. Next. High vascular selectivity of benedipine. Coronary artery selectivity of benedipine is 19 times higher than that of amlodipine. Very important. Coronary artery selectivity, that's why anti-angina drug, it has got 19 times higher than that of amlodipine, 14.4 times higher than that of nifedipine. Vasodilatation, reduction, and vasoprotective effect by this is more. Potent vasodilator of the coronary cerebral and renal vasculature. This is the effect of benedictine. Next. Now, superior cardioprotective and anti-atherosclerotic agent is it stimulates nitric oxide production, I know, It prevents endothelial cell dysfunction because of nitric oxide production, has antioxidative activity, suppresses the expression of adhesion molecule. It suppresses the proliferation of vascular smooth muscle. It protects the myocardium. So enhancement of nitric oxide production is associated with cardioprotective and anti-atherosclerotic effect. This is how it is superior cardioprotective and anti-atherosclerotic. Next. Now, to give roughly effect of benadryl on podocyte, we said initially the reader it reduces podocyte loss and that way reduces Podosine and nephrin loss. So less proteinuria. Proteinuria is controlled because we have effect of benadryl on podocyte, suppression of the development of proteinuria greater than amlodipine through a inhibiting N-type calcium channel on podocyte. So it is independent of its antihypertensive effect. This is different. Elicit podocyte protection and that way anti-proteinuric effect. Next. Benadryl suppresses the progression of nephron loss. Clinical studies reveal that benadryl suppresses the progression of nephropathy, reduces glomerular blood pressure, as we can see the renoprotic effect. A marked increase in renal blood flow we showed in the previous slide, and nephrotic effect it causes diarrhea little, enhance nitric oxide formation in renal parenchyma makes it more endothelial protection. Next. Benadryl decreases glomerular hypertension and proteinuria, dilates afferent as well as efferent artery. This is the beauty of this molecule. Reduce glomerular pressure and that way damage. Benadryl is the only as working on afferent and efferent. Amlodipine has only an afferent and nifedipine on efferent. Next. Comparative clinical evidence of benadryl and cilnidipine. Next. Effect of benadryl hydrochloride, long-acting T-type calcium channel blocker on blood pressure and renal function on hypertension patient. So this is the effect of benadryl on long-acting T-type calcium. CBC studies benadryl versus cilnidipine. 40 hypertensive patient with diabetic diagnosed at outpatient clinic. Initially treated with cilnidipine 5 to 20 and switched from cilnidipine to benadryl 2 to 8 milligram. Next. Okay, result. Potent antihypertensive effect of benadryl compared with cilnidipine and its beneficial effect on renal function, indicating a high usefulness in hypertension complicated by diabetes. That was seen in those trials. Next, comparison between the anti-proteinuric effect of calcium channel benadryl and cilnidipine in combination with angiotensin receptor blocker hypertensive patient with chronic kidney disease. What we show the result that benadryl group, as you can see, nephrotic syndrome patient and cilnidipine group also in thing. The serum albumin levels were significantly increased and number of patients with nephrotic syndrome was significantly decreased at the end of the study, showing that this has got more effect on benadryl plus ARB versus cilnidipine plus ARB. More proteinuria reduction, single center study though it is, but number of patients 223. Next. What we see the result that changes in urinary protein C subgroup according to different baseline etiology of kidney disease. Urinary protein CR ratio, age, sex, and BP. The anti-proteinuric effect was superior in the benadryl group compared to the cilnidipine group. What we found in conclusion that addition of benadryl as well as cilnidipine reduces blood pressure and urinary protein excretion in hypertensive patients with CKD who are already being administered ARB. On top of ARB, whether you had cilnidipine or whether you had benadryl, the effect of proteinuria was seen. Both benadryl has the potential to be more effective on reducing proteinuria. Next. Again, effect of benadryl hydrochloride, a long-acting calcium channel blocker on blood pressure and renal function in hypertensive patients with diabetes. The participants were there, load of 40 patients. Next, we'll go to start the result. Changes in blood pressure of hypertensive patients with diabetes mellitus. So, next. अरे ये क्या हो ये यहाँ आ गया Next. Now result BP significantly decreased from this 155 to this, and after benadryl treatment and effect was stably maintained for a year. Urinary protein also significantly decreased from 1.29 to 0.676. So what we had the conclusion that this clinical trial demonstrated a potent antihypertensive effect of benadryl compared with cilnidipine and its beneficial effect on renal function, indicating a high usefulness in hypertension complicated by diabetes. T-type calcium channel blockade was suggested to be positive, possibly involved in renoprotective effect of benadryl. So T-type calcium channel blocker was probably giving us more renoprotection, especially with benadryl. Next, benadryl versus cilnidipine. The summary, if we see the parameter calcium channel inhibition, cilnidipine L and N, but benadryl got a triple channel T also, and which was showing the effect. Duration of action, cilnidipine intermediate, benadryl long acting. Protection was seen in both, benadryl slightly more. Of course, dilatation of afferent arteriole was seen in both because of those Allen channel. Pedal edema was both negligible. Reduction in blood pressure was less with cilnidipine, more with benadryl. Next. Then reflex tachycardia, there was no reflex tachycardia in both the groups. Vascular selectivity is equal. Urinary protein unchanged, but the urinary protein increase in benadryl. Increase serum albumin. Cilnidipine, no. Benadryl, yes. Decrease nephrotic symptom, yes, in benadryl group. Next. So a lot of advantage of benadryl over cilnidipine. Benadryl comparison other CCB, you can see that because other CCB like amlodipine has got only L channel, cilnidipine L and benadryl is triple. Action long acting, intermediate long acting. Benadryl renoprotection is more with benadryl than amlo and cilni. Dilatation of afferent different arterioles. It can only afferent arterioles greater risk of glomerular hypertension, both in cilni and benadryl. Pedal edema, yes, with amlodipine, but it was not with benadryl. Reflex tachycardia, no, with the benadryl. It was there in amlodipine. Vascular selectivity 19 times less than benadryl. Next. With this, I conclude the talk. It's very important molecule we have discussed, benadryl, less talked about, but very wonderful molecule. As you can see, the L, N, and T type channel blocker. T giving more protection renal, and L only the one, and giving a neuron protection sort. So high reduction in the tachycardia, edema is not there. So much more advantage are there with increase in serum albumin. With this, Jansi, I conclude my talk. If any questions are there, I'll be more than happy to answer. I have to be little faster, but then because the slides were so many,
Yes,
Okay.
sir. Thank you so much, sir, for your insightful presentation and for sharing your valuable thoughts on this topic. It is a very insightful session. So, sir, there are some questions come from the audience. So, should
Okay.
I read for you?
Yeah, please do.
Okay, so a very first question is from Dr. Arijit. Is benidipine safe during pregnancy?
Benadryl is safe during pregnancy cannot be predicted because there are no trials as such with calcium channel blocker, but we use as L-type amlodipine also safely. But then there are no data and there was no separate studies with pregnant patients.
Okay, next question is from Dr. Subhashi, sir. What is the EGFR range for using benidipine?
What did you say? Repeat.
Okay, question is, what is the EGFR range for using benidipine?
Okay. Anything above 30, 30 to 60, we can use this benadryl, not below 30.
Okay, one more question from Dr. Subhashi, sir, is there any changes of reflex tachycardia after using Benitua 8 milligram once daily?
No. There is no reflex tachycardia because of T channel iron, because the load of reflex tachycardia we get in L channel blocker like amlodipine. There is no reflex tachycardia.
Okay, so sir, as of now, there are not many more questions come. Can we wait for a minute if they have any query or question?
I will.
Okay. Dear participants, if you have any query or question, you can post it in chat box.
Thank you. It was a very wonderful session. In fact, I'll say this is a very wonderful molecule. Less talk, they are not many people. So this should be useful to the doctors who are listening. I find this molecule very, very useful, and this is a good molecule, very well tolerated, and of course 2, 4, 8 will come there. So with this, if not there, we can conclude the session.
Sir, there is one question come. Should I read?
Oh, please do.
Yeah. In which hypertensive patient profile do you prefer benidipine over other CCBs?
In which
Okay. In which hypertensive patient profiles do you prefer benidipine over the CCBs?
this is a very interesting question because other CCB or what, but in CCB, those who have got tachycardia, those who have got light pedal edema, and in those patients who have got angina, this benedipine will be better than other conventional CCB.
Okay. One more question here.
Yeah,
How does benidipine help in reducing the incidence of pedal edema compared to almedipine?
yeah. Because of this, it causes both arterial and venous dilatation is reduced, and which is not in by semlodipine. This causes less reduction in the edema. There is no peripheral leakage in the arterial and venous venues, so it causes less.
Okay, next question is, can benidipine be effectively used in combination therapy for better BP control?
Yes, there's a lot of these studies because benedictine can safely be used with AS or ARB. And in fact, this is what we use, and this gives a much better blood pressure control. So, and benedictine can be used with ARB or AS inhibitor, very, very safe and selective. Thank you.
Okay. Next question is, what is the role of benidipine in patients with hypertension and early renal impairment?
Hypertension and early renal impairment, it is very important because see how does it? It protects the kidney, it reduces proteinuria, it reduces albuminuria, which is the hallmark of to give in patient with kidney disease. So the kidney disease progression is halted. Benedipine can safely be given the patient with in comparison to amlodipine and other medication. As a CCB, this is a very good molecule we can use in early stage of kidney disease.
Okay, so there are no more questions, sir. I think your presentation has covered up most of doubts and queries from the attendants. So there are not further questions come. So your guidance and your practical knowledge, sir, have been truly informative and beneficial for all of us. And we are very grateful for your time and presence today. And it has been a privilege to learn from your experience.
So
So
we
once again,
learn from the different questions. And thank you, Jessica. This is always a pleasure to interact with fellow colleagues. We always learn, and when our knowledge becomes much more, and your slides were good. Thank you.
yes. So once again, thank you so much, sir, for giving your valuable time. So now, with your permission, shall we conclude this session, sir?
Welcome. Thank you.
Okay. Thank you so much, everyone, for joining today's session. And thank you, Dr. Kamal, sir. So from here, ending this meeting. Thank you. Have a great evening, sir.
Okay.